You are going to love today's episode.
And in 2007, the World Health Organization said shift work disorder is a likely carcinogen, a likely cancer-causing agent. It blew out of the water what we saw with duration of sleep, because we saw that even within a 1 to 2 hour difference of your regularity, we started seeing that accumulated risk. And when you then looked at a shift worker or otherwise, that risk really escalated. It went through the roof. I would say it is a cancer prevention strategy for you to try to have as regular sleep.
Welcome to AI in Healthcare. My name is Dr. Sanjay Janeja. I'm a hematologist and medical oncologist, also known as the Onc Doc on social and news media, and I'm joined by my co-host, Dr. Douglas Flora, who is, amongst many things, the chief editor of AI in Precision Oncology, senior leadership at St. Elizabeth's, incoming ACCC president, etc. And if you are an OG listener, so you listened to this podcast back when it was Target Cancer Podcast, you are going to love today's episode. It is a real treat because we're going to talk about things that have to do with really the physiologic, mechanistic stuff in a way that everyone is interested in, which we don't get enough about, right? When it comes to sleep and inflammation and the immune system and how the immune system affects cancer or cancer responses, and maybe how the microbiome affects all of these things. This is an area of interest that, in my personal opinion, is not investigated nearly enough, and we could not have anyone better than Dr. Marie Morse, who is joining us to really tell us, with the inclusion of AI, not just in the way of machine learning, which we've used a long time when it comes to sleep and immune systems, but also what we can now trace with wearable data and all of this, this ring stuff and watch stuff to really appreciate what's happening with sleep, what that could potentially translate to when it comes to our understanding of why people do and don't respond to therapies, how those things can be ameliorated, and really what our body does even without therapy to fight cancer. So with all of that said, Anne-Marie, it is super awesome to have you.
Thank you so much. I'm really excited to have this conversation because I do think that this is an emerging area in oncology of really trying to better understand the full 24 hours for an individual. Most typically, when people would talk about sleep and oncology, it most typically was a reflection of a PRO. And that sometimes doesn't get people tickled with excitement of just thinking about a patient-reported outcome, although that tends to be my guiding light. So now we can actually talk about how chronotherapy makes a difference, how we can use sleep and circadian as a tool for not only cancer prevention, but maybe even helping to optimize the intervention and potentially even predicting those who are at risk for recurrence of cancer.
I love it. And, this unfortunately had become an area of interest that's been a kind of a buzz in the last year or so, when data came out saying or showing that immune therapy, the timing of immune therapy, and I believe that's how our conversation started when I met you at AVBCC. I was like, yeah, the data on the timing of the day of the immune therapy in the morning versus the afternoon had some pretty shocking difference in the percentage of responders and how long they continue to respond to that immune therapy, especially in a melanoma cohort. And I believe the first thing you started with, and I would love if you could set the table for us in that capacity, was really talking about this whole concept of circadian genes and, the lymphocytes and immune cells, and how we actually have genes that kind of affect those things, not only in the quality of sleep, but even kind of, again, set the precursor for what kind of regulation we do or don't have in a genetic or germline way.
Yeah. So one of the things I always like to emphasize is that many times people think about sleep as kind of this optional time of day. And really, this is rooted in the systems of medical education. Since 400 BC, the initial descriptions of sleep were they're a temporary coma. And this type of mindset had persisted until 1989, where there still was this consideration of optional sleep. So that's just talking about sleep medicine. What we're really talking about is sleep and circadian health, which are connected but separate. What do I mean by that? In order for me to have sleep-wake regulation across 24 hours, there has to be this beautiful orchestra that is played to create this harmonization of your homeostatic processes that are going to force sleep, your circadian rhythm, and being able to organize those so that there's the optimal timing of the sleep gate opening, and then also for me to be able to wake up and feel all rested and restored. Although I can spend a lot of time talking about the restorative natures of sleep and all the roles and processes, the unsung hero really is the circadian processes. And when we talk about circadian health, if I were to be in an audience, lay audience, medical audience, some of the most well-recognized clinicians or researchers, and ask a question around what drives our circadian rhythm, you'll almost uniformly have people respond with, oh, suprachiasmatic nucleus, your melatonin. I'm like, that's partially correct. The truth is, in 2017, a Nobel Prize went to three men who identified and molecularly characterized the effects of clock genes. These are genetically imprinted details that tell us not just when to be awake and when to sleep, but when every single cellular function should have a peak time of expression. It means that every single thing in our body has a time that it's going to be at its most and it's going to be at its least. It is really very symbiotic to the thought of everyone has a circadian preference too. I know when I'm at my best and when I'm at my worst. It's the same reason if you're a sports fan and you think that the home territory advantage is all about just being where the local fans are. No, if you're traveling time zones and you're looking at evening sports, you actually have an extreme disadvantage. And there's a 30 to 40% likelihood of the team that is traveling the time zones is going to lose. And so substantial that there was a paper that was published on this, that then they took that same data, went to Vegas, took the odds, and the bookies couldn't believe it. They're like, "There's no way, you guys are crazy." Let me tell you, they walked away pretty handsomely. So when you think about that, it's not just talking about how can I win the bet on the teams, it's how can I win the bet on my body? And so if you were to look at some of the research that has been done, there has been a mapping of the peak time of expression of a variety of different activities that our body does. The example I typically will utilize when I'm giving presentations and have a slide is showing in the early morning hours, you have a couple of things that are peak time of expression. And those things include things like renin, angiotensin, aldosterone, your highest blood pressure peak, your platelet adhesiveness, blood viscosity. And as I start pointing those things out, all overlapping in the same time, the people in the audience, especially if they're clinicians, are going, "That doesn't sound so good." And if you were to do a peak time of expression of disease overlying that, you see myocardial infarction, stroke, angina. It's not by accident. It's not coincidence. It's circadian. So when talking about cancer, this isn't a new concept. It's 2026. And in 2007, the World Health Organization said shift work disorder is a likely carcinogen, a likely cancer-causing agent. And it is not because of the fact that they're like, hey, we just don't like these shift workers. It is because of the fact that we are seeing that they're more likely to have breast cancer, prostate cancer. And there's even evidence to demonstrate that every year of shift work that an individual does greatly increases their risk, up to almost 3% per year of developing things like prostate cancer. So when we're seeing that the World Health Organization is saying that this is a likely cancer-causing thing, you would think that would grab attention. You then would think that one of the most common chemotherapeutic agents that are utilized for solid tumors is something like 5-fluorouracil. People know this drug. When you look at 5-fluorouracil, it is dependent on an enzyme that's produced by the gene DYPD. When you look at the gene DYPD, there is 1% of the population who doesn't produce the enzyme at all. So they have a mutation that is a null mutation, doesn't function. Then you see 3 to 8% of the population who they make insufficient amount of enzyme. So almost 10% of the population who may potentially be exposed to 5-fluorouracil, you may want to think about doing gene therapy. I presented this at ADBCC, and the response that I had received was, no one does that in the United States. So I pulled up, I said, you're right. In the United States, it's recommended you have a discussion. Everywhere else in the world, it's mandatory to test for this before you give 5-fluorouracil. Why? Because if I don't produce the gene, I should look for an alternative agent. If I do produce the gene and it's in an adequate amount, I should be using a lower dose and timing it earlier in the morning because the peak time of expression of DYPD is around 4 a.m. And so this introduces the concept of chronotherapy. Now you're seeing a concept being illustrated by 5-fluorouracil related to me being able to metabolize it. So if I have something 10% of my patients are going to benefit from, there's no way I'm ignoring that. There's no way I'm skipping that step. And I'm shocked that the payers haven't made that as a mandatory step before giving delivery. You now fast forward to not just within the last year, this has been within the last 3 to 5 years of multiple systematic reviews and meta-analyses, propensity score matching analyses that have looked at the time of day of administration of immune checkpoint inhibitors. And if you were to talk to me even before any of this literature was published, and you said, Anne, let me ask you a question. If I'm going to give something that is going to inhibit the expression of an immune cell, do you think time of day matters? I'm like, absolutely. Absolutely. What are you trying to inhibit? We need to know what the circadian timing is. Otherwise, you're going to give a toxic placebo. If I'm at its trough and I'm giving you something, I am going to just enhance mortality. And lo and behold, what do we see? Up to a 4-fold difference in survival. That to me should be we need to make a hard stop. Again, I presented that data to oncologists. And what was the response? I don't believe the data until there's a randomized control trial. Well, you know what? There's a randomized control trial that just published this year, and it's demonstrating the same exact thing. And so when looking at this, it's an important piece that I want people to hear is that although it sounds very exciting to say, okay, now we're going to do everything in the morning, that is not the answer. It is important to know when you're talking about the circadian rhythm, we need to think about what is the peak time of the thing I'm trying to act on? What's the peak time of the thing that is going to break it down? And also, if there's a certain side effect that you see, let's say bleeding due to platelet aggregation issues, maybe you want to think about the peak time of that platelet adhesiveness so that I can mitigate the risk. We currently design our drug trials and delivery of drugs based on PK/PD. And that is an inferior approach because you may not need the bigger area under a curve to have the bigger magnitude of effect. You may need to consider what are the individual factors in the circadian players that are going to influence the desired outcome that you're going for.
This is just a whole nother dimension or level of precision medicine, which I'm sure gets under Anne's skin and just kind of makes her like, ugh, like, why should it be? Or because it's nothing new. But, we're just not there yet on really thinking about these things. I remember when she told me about these circadian genes, I think there's one called CRY2 that for hepatocellular, machine learning was able to find that that's even a kind of a prognosticator and potentially for therapeutic response. And that was just one example of how these genes actually get you a more precise idea of how to treat a patient. I know, Doug, that you started the fluorouracil DYPD testing kind of across the board on every patient at your center. So, you're on top of it. But is this stressful for doctors to hear about how there's a whole other component we're not thinking about?
I think what you're referring to is the same thing you and I always talk about. It's the difference between the quality of care we think patients should receive and what they actually receive. Because these aren't new data, right? And we have understood this. We know that circadian rhythms affect immunotherapy outcomes all over the place. We know that dendritic cells, we know that T cells, they fluctuate. They have their own circadian rhythms. We know that, and we should be cautious for our audience. This isn't night and day because people sleep in different cycles. People work at night, people work at day. It's a rhythm issue. It's a pattern recognition issue, which gets into some of our AI conversations, because I think if you're in the audience and you are not a neurologist slash sleep specialist, you tend to get paralyzed when you start to hear things like this because it's too much too soon. And I guess what I would say for the audience, we understand that this is where the AI will come in and take these impossible to decipher puzzles and say, all right, there's 500 features that affect the ability of this patient to respond to immunotherapies. 7 or 8 of them might be related to circadian rhythms. 6 or 10 of them might be related to other drugs. Some of them might be their own gut microbiome. And that's just getting increasing levels of complexity that go beyond the pale for those of us that have to make these mildly data-informed judgments without being able to assemble the whole picture. And you and I were talking before we got on about the way we approach systems. And I think the timing is right to maybe talk about that for your work, because here you are, you're blending 3 or 4 different specialties at once, and it's rare enough to have a neurologist that actually understands these things, but to have neurology and sleep, which are so intimately related. Maybe walk us through a day in your life at Geisinger and your other, the other hats that you wear so the audience can understand the platform that you're speaking from is a very, very unique one. So if the things that you're saying sound outlandish, it's because you're one of maybe 5 or 10 people in the country who have the training that you have
Yeah.
in both disciplines.
Yeah. So my background is I'm a neurologist with special qualifications in child neurology, and then also fellowship trained and board certified in sleep medicine. For close to the last decade, I had run a division of child neurology, created a division of pediatric sleep medicine, established a child neurology residency program, stood up a research program, and then also did a lot of work with our digital transformation innovations team. And so created a modular remote command center model of doing education and screening for a variety of different things. We had it in the school system, and then we also have it in our health plan as well as in our clinical enterprise. And across the last 10 years, I've had the privilege of really getting to be a part of a variety of different arenas. So I'm considered a thought leader in rare sleep disorders, conditions like narcolepsy, idiopathic hypersomnia, and across that, work with a lot of the pharma companies, work with a lot of diagnostic companies, everything from your startups and beyond. Over the course of the last 6 to 12 months, I've made a big transition and have kind of reduced my time within my healthcare system and now focusing on really bigger global movements. Part of that is being chair of an advocacy organization called the Wellness Sleep and Circadian Network, which is really representative of what we're having a conversation of. Is it's owning all 24 hours to achieve the best version of who you're going to be, and it's blending the sleep and circadian variables with across the body. So there actually is quite a prolific amount of information on there for patient facing, but it's not limited to your 8th grade level. And then I also have just stood up a 501c6 business alliance that is called a Unifying Care for Advancement Network, the acronym UCAN, where when care unifies, you can do more. And so that really is helping to solve the problem of there's a lot of independent silos that aren't connecting. And some of that has to do with compliance, and some of that just has to do with accessibility. So really driving at how you can make this as a part of a global health learning system. So the way that I actually fell into the oncology part was really because of the fact that as a person who is expert in hypersomnolence disorders, an integral part is orexin. And orexin has a very, very significant role, not only in sleep-wake control, but also circadian rhythm. And because there are orexin receptors on a suprachiasmatic nucleus. But there are 2 pathways in orexin. There's orexin 1 and 2. They're 2G coupled proteins. And so when you talk about those, you're already dealing with a really complicated system. But orexin is actually really quite pivotal in regards to cancer. And so there's everything from the most recent literature giving a suggestion of giving cisternal injection of orexin A, and that potentially being a modifier of glioblastoma multiforme, to giving orexin 1 receptor agonists, and that potentially causing a recession of GI cancers, specifically colon cancer. So with this stated, I started to have conversations with more and more oncologists about this and realized that really no one was talking about it. It wasn't until my mom was diagnosed with a non-small cell lung carcinoma of a mixed mucinous, non-mucinous adenocarcinoma that it became really glaring in my face of how much is missed in regards to where that opportunity is. And it really became a call to action for me to start having these conversations. So I told my program manager, so she that covers all my projects. I said, start cold calling oncology companies. I want to talk to them about circadian rhythm. And it's been very interesting because it actually has met, for the most part, with a very positive reception. Most recently, I had one email where they were like, oh, this doesn't align with our portfolio and our future directions. And I said, well, I apologize, and I hope your company continues to do well because everyone else's portfolio and future directions in cancer seem to be responding to it. So I do think for me, I've been very fortunate because I get to do a lot of these things. The part that I'm most excited about, which I was sharing with you guys beforehand, is as a part of reducing my time, it was because I have this really cool opportunity that I get to work with a multi-omics diagnostic company called Nanomosaic based in Waltham, Massachusetts. And they had presented to me some of their technologies. They can do everything from nucleic acid to full protein on a single chip. And I said, this is really cool. And they are really focusing on gene therapy at the time. They currently now are the first and only company that actually has an FDA clearance on doing superior analytics on gene therapy. But the part that really impressed me was when they were showing me some other work that they were doing in postoperative delirium, brain health, inflammatory, et cetera. And I said to them, "So you mean to tell me on a single plate that I can put multiple of these on there and it's not gonna cross-react, it's not gonna, because they have this novel nanoneedle technology, and usually you can't do those things. It's like four different things, and beyond that, you're gonna start getting crosstalk like crazy, and they're like, "No, it's not going to cross-contaminate." So it introduced a concept that I think is really necessary for really medicine in general to acknowledge, and that's that biomarkers are a lie. And when I say that, it sounds like heresy for people. And the reason I say that is because a biomarker gives a suggestion that you can identify any patient with a certain disorder, and that it may give you some inclination as to the duration that they've been living with the disease and the level of disability or dysfunction of the system. That's not gonna tell you that. So if the biomarker goes away, it doesn't mean the disease has gone away. You just lost the thing that you were following. You now are shooting in the dark. What we really are trying to step back and do is, how do we do a clinical profile? How are you able to actually look from a system perspective? And I think really when you're talking about cancer, especially when you're talking about tumor microenvironments, this is where we need to go. We need to be able to understand the full system, because what's going on locally at the cancer level and what's going on in the rest of the individual may be two really different things. And even when you're looking at things like antibody drug conjugates, that sometimes is leading you down a path of, again, thinking that you're gonna get at the right target all the right time, but you may end up taking out some other really important things. So I would say that I've become increasingly literate in oncology. I still have a lot to learn, but I would say that the passion and motivation to be able to make an impactful change on how oncologists, both clinical and researchers, think about this, and then layering in where AI is going to be able to help us in better modeling these and being able to think about what do we need to do and when, I think is gonna be really, really transformative.
Yeah, like I personally held off forever when it comes to, actigraphy. I don't even know if I'm pronouncing that right. Measurements, right? Or wearables. So meaning like sleep monitoring stuff. And I said, well, it's because I know how much I have to work and I sleep as much as I can sleep. I can't change my behavior. That used to be my opinion. And now, I'm like, well, but I could still get some insights, potentially, as this stuff kind of evolves over time on like what the, sleep stage is. And God forbid if, I get a diagnosis or a certain pathology, are there trends that you could kind of see that could potentially help other people? I'm a big advocate for, sharing data responsibly when possible. My point in saying that is, when it comes to sleep and to the same thing that I just said about like, oh, well, can I help? I'm really wondering or curious your thoughts on the chicken or the egg phenomenon. And I think we might have touched on this when we met in person, but like, there's studies that show that plenty of studies when it comes to sleep, how much better individuals can do or have a lower chance of having issue. I believe there was one with about almost 61,000 UK biobank participants, and they showed that a higher sleep regularity was associated with 16 to 39% lower cancer mortality. And you can find these in many places. There was another study in Nature Communications in 2025. My point in saying all this and asking this is that there's certain tools, there's a lot of tools actually measuring, the how likely somebody is to respond to immune therapy. A couple are Loris and Scorpio, that NCI, Memorial Sloan, Mount Sinai use that do not include sleep. And I already know I think your opinion on that. But what I'm really curious is, are these assessments of sleep due to a lot of them being germline or inherited? I don't know if it's a lot of them, correct me if I'm wrong, inherited, circadian rhythm genes. Someone has, quality ones, someone maybe has fragmented ones. Is that all mostly in the prognostic bucket as far as like we just know that these patients are probably going to not do well or as well or et cetera? Or do you think there is a significant wiggle room to be able to potentially help these things out. And I guess we didn't draw the full circle. Obviously immune therapy works on lymphocytes and lymphocytes, antibodies, stuff, that whole lineage of the immune system we know gets downregulated when it comes to and correct me if I'm wrong, elevated levels of cortisol and stress hormones. And that's why when you give steroids, you end up seeing the lymphocyte count lower. Walk us through perhaps how you feel about chicken, egg, little bit of both.
Yeah, I think that there is going to be some individual variation. What we know is tends to be a bidirectional relationship no matter what we're talking about. So the first thing that I always like to step back and say is that the brain is your master controller, right? And although there's a lot of autonomy that other parts of the body can do, generally it's also offshoots of the autonomic nervous system, which is still coming back to the brain. When you look at sleep, and the reason why I love sleep as an example is that sleep, number one, is a homeostatic process, and there's a natural ontogeny to sleep. And what do I mean by that? I mean that there is a natural developmental process to the timing, the regularity, the duration of sleep. In the first year of life, it is estimated that a child should sleep 14 to 17 hours, and that's not all at once. It's fragmented across the day, and that's intentional because of the fact that the role that sleep plays is so significantly active, especially in terms of learning consolidation. And so we see this, again, repopulating both from the neurodevelopmental and the neurodegenerative, because that process is not just having synaptic pruning or reinforcement. There's also the lymphatics that is trying to get the garbage out. And that's a really hot topic when we're talking about it from a neurodegenerative. However, as we're continuing to develop, we're going to see that there's this consolidation of sleep and that daytime napping should go away by the age of 5. The reason I give this description is because most of us are pretty much programmed to have a pretty consistent pattern with what has been designed, right? Now, when you're talking about the extremes, and last year there was a big sensationalization in the media that the SIC3 gene, if you have this point mutation, that you could be a congenitally short sleeper. And it's like, see? And it reinforced the mentality of the majority of US Americans that, see, I can get away with less sleep. What that media sensationalization failed to identify is I can do a point mutation in a different area and you're a congenital long sleeper. All it told me is that it controlled my homeostat. When you're talking about clock genes, most of us, our chronotype is generally kind of an intermediate. However, even when you do these kind of surveys that are asking like morningness, eveningness, that's asking your circadian preference. It's not giving you your chronotype. So when you describe like, this is just how I sleep, it's not because you're programmed to sleep that way. It's because over years of choosing a certain way of sleeping and being awake, you've adapted, and it may be maladaptive, but you adapted to that. And therefore, you've conditioned yourself to believe that that's the best version of you. But if you were to go back into what is your genetic circadian profile, you likely would be, number one, healthier, but also you would probably be much more vigorous, alert, interactive, etc. So when saying which is the driver, we know that people who have sleep and circadian problems are at higher risk for many morbidity, including cancer. We know that when you have cancer, it is going to cause complete derangement of your sleep and circadian profile. And why is that? When you're talking about an oncologic experience, you are talking about immune dysregulation. And when you're talking about the things that normally are influencing your sleep-wake control, we go back to kind of the simple process of thinking about a homeostatic drive and circadian rhythm. Your homeostatic drive, we generally will attribute your kind of constant accumulation of wanting to go back to sleep to adenosine. And so if you think about adenosine triphosphate and not being utilized all day long, just the reason why when you were studying for boards, you'd be like, I don't know why I'm so sleepy. All I did was sit and look at this book all day. It's because your brain was using a whole lot of adenosine triphosphate. However, what's neglected in most conversations about the homeostatic drive are things like tumor necrosis factor, IL-6, IL-1. These are also going to contribute. We're also going to neglect IL-6 is going to increase the permeability of your blood-brain barrier, which also is supposed to have a circadian pattern. And that's going to increase the likelihood of you having quote unquote chemo brain fog. And that's not even talking about all the other dysfunctional processes that are going to occur. So there's not the single thing. I love the fact that you referenced the 2024 Windred et al. Paper where they talked about the regularity of sleep, because it is one of my most favorite papers. Because the challenge with a young field like sleep medicine, which only came onto the stage in the 1970s, is we're still a bit erratic in telling people what's important. And so for a long time, we're going, it's duration of sleep, it's duration of sleep, it's duration of sleep. And the same statistical analysis that was applied for the Windred et al. Paper was done for regularity of sleep, which revealed this J-shaped curve that less than 6 hours, you had increased all-cause mortality, greater than 9 hours, you had increased all-cause mortality. So we were like, sleep, sleep, sleep. It's so important. And that was actually the reason that the American Heart Association changed Life's Simple 7 to Life's Essential 8 in 2022, was adding in sleep. Everyone thought it was OSA. Nope, it was actually duration of sleep. They thankfully have also further expanded since this paper came out, because what the Windred et al. Paper did is that it looked at the regularity of sleep. What does that mean? How consistently are you falling asleep or going to bed around the same time, and how consistently are you waking up around the same time? The more consistent you were, the healthier you were. And when you looked at very erratic sleep, people fell off the cliff. And in fact, it blew out of the water what we saw with duration of sleep, because we saw that even within a 1 to 2 hour difference of your regularity, we started seeing that accumulated risk. And when you then looked at the like a shift worker or otherwise, that risk really escalated. It went through the roof. Now, I say all of this to say we can't become a zealot for any singular thing. Our brain especially is a network of different connectomes. And so we always have to think from that system perspective. There was another paper that, and I want to say it was in 2024 as well, that had looked at the differential effects of sleep deprivation versus circadian disruption on the transcriptome. And it had demonstrated, because of the fact that every cell has a circadian factor, and things like cry and BMAL and PER, they're present throughout the body. When you have a circadian disruption versus a homeostatic disruption, you saw organ systems having differential impact. And even when you're talking about the microbiome, there's a circadian rhythm to the expression of the different species and the diversity that you're going to see. So I would say to you that when we're looking at sleep and circadian, I would say it is a cancer prevention strategy for you to try to have as regular sleep. Is it going to prevent all cancers? Absolutely not. Is there an opportunity for us to also think about this when we are treating patients with cancer and monitoring them post-treatment, and where we think that they're in a good place? I do think that that would make a difference. I think that we're still lacking in regards to the data to fully support that. But I would say we really would need to look at it. And I would give caution of saying, well, just follow the person's circadian pattern that they're using. That might be the culprit. You may not want to follow that circadian pattern. It may be that we do need to look at those clock genes, and we do need to think about what the circadian expression of other things are.
I feel so naive because, and I don't think I've ever said that on the podcast, but I've like, not that I'm not naive, not that I'm not
He's
naive.
very naive, Ann.
Yeah, but at least admitted it. No, I am. But I remember just so many times when my patients, like, I'm having trouble sleeping, I'm having trouble sleeping. I remember just always thinking to myself, like, how, like, it must be so exhausting to have cancer and cancer therapy and travel, and it always kind of surprised me. And honestly, my conclusion was like the stress is keeping them up. And the way you explained it was so beautifully put. I mean, you have all these inflammatory, signals and cytokines and all this stuff, interleukins that are kind of disrupting just that homeostatic process, right? And what I find, one thing that I did at least hopefully know well enough was to your exact point, even if I can't make them sleep, I was very keen on not disrupting as close to the natural process as possible. So correct me if I'm wrong, but I generally avoided, benzos, not generally, I still avoid benzos or Ambien or things that I read to be more disruptive in the REM cycling. I'm told, correct me if I'm wrong, that trazodone, of the options might be one of, if melatonin fails, to be potentially one that if they, they're insistent, and I'm sure that's his own episode. But my point in saying all of that is, one, it's a very natural process on why that disruption's happening. Two, the chicken or the egg, you could see it become an issue because it's like, oh, is it the sleep or is it the cancer? And it seems like exactly what you said, bidirectional, a little bit of both. And then, disrupting it at the least, right, Doug? I mean, what does this information, kind of tell you? And before I ask that, this is where I get very excited about what foundation models and AI can do if you can dump data properly. Because if you can just take a whole bunch of people and say, yo, I don't know why these people don't have the same duration of response, and somewhere down that Plinko chip it says all of these are given Ambien or benzos, and you can start seeing correlations that can hopefully guide our behavior better, because the mind doesn't know what the eyes haven't seen.
I wanted to take her back to that because what she said, I don't know that our audience maybe is familiar with her work, but one of your, I guess it's Morse code, right? Is own all 24 hours, right? This phrase, it's everywhere in your work. It's WSCN's mission. It's Sleep Timber's tagline. And I think that's really compelling for us. I would say, as the AI enthusiast, as somebody who sees this, I think you were ahead of the curve. And we may now finally have the tools to extend care 24 hours a day, whereas it used to be
Absolutely.
8 to 5.
Absolutely.
Yeah, and now you have wearables. My wife and I, we both wear our Aura rings, and every morning the first question she asks me is, "How did you sleep?" And I'm like 59. I don't say how I slept. I give a score. I give an objective number, which is, I know, false, but it's also so satisfying to have an objective measure for I slept worse than you in a marriage. That's critically important. I'm more tired than you are is so important that I can objectively monitor that. But is AI the thing that finally makes owning all 24 hours possible at scale? Or is that overselling what AI can do already?
So I think really what we're looking at is how do we evolve a current model of care which is consistent of transactional episodes to really be a continuous longitudinal model of care, right? And
Exactly.
so I think that one of the things is it's always necessary for us to have responsible stewardship of what is AI's role and how does it help us to facilitate the in-between visits? How does it help us to facilitate the clinical trial selection and monitoring of the outcomes, translating that into what real-world evidence generation will look like? And so what I think is that we need to ensure that, number one, that clinicians and patients both understand their roles, responsibilities, scope of work. And so many times a patient hasn't been adequately educated on this is the information we need to best identify and treat you and monitor you, right? And so they sometimes are coming in and they're using the wrong lexicon. We published a paper last year around this, and we do a lot of work on trying to correct the lexicon substitutions because even where you say I woke up and I'm more tired than you, what does tired mean? Tired most typically is the reference of someone who's having fatigue or exhaustion, not sleepiness. However, if I come in, I go, I'm so tired, exhausted, and I mean sleepiness, I may reroute you down the endocrinology, infectious disease, psychiatry even, where I come in and I'm so sleepy, and I do lexicon substitution as your clinician and go, "So how long have you been fatigued for?" The patient needs to know, "That's not what I said, that's not what my symptom experience is." So the role and the reason I say that this is important
Interesting.
is because AI, and even when you do a deep learning algorithm, it's only as good as the data it's analyzing. And if we are only giving partial components to it, we're going to potentially misdirect how it should learn. Unless there's something that's like, hey, this doesn't make sense for the pattern you gave me. I haven't seen the algorithms do that just yet. And so, with that stated, the reason that I answer with a bit of trepidation is because, as I shared, I do rare sleep disorders, and I was a huge, huge advocate for bringing in ambient listening artificial intelligence scribe services. I was like, it's going to learn, it's going to hear me with my patients, it's going to learn, it's going to create outputs that are going to inform other clinicians who may not see it. It's going to lead to like, would you consider XYZ diagnosis? And I always tell people my very first visit that I utilized this in was with a young woman who had narcolepsy. And I go, the visit went something like this: sleepy, 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 sleepy. And I had this one night where I couldn't sleep because of my anxiety. And then we had about a 20-minute conversation around suicidal ideation. And the output was the 25-year-old patient with a history of insomnia. And I was just like in fatigue. And I was so discouraged. I went to the company because we're working with the company. Go, the model was trained on primary care. And I said, the lexicon substitution is a problem because it's not giving me subspecialty output. And so when I think about AI, I use that example not to say AI is terrible, but it's with caution, because when we're relying on AI and we're not thinking about what is the perspective it's coming from, right? It only is going to mirror the errors we see in humanity, which is intention, perception, and perspective are three different things. And unless you gain a fuller perspective, you are never going to be able to get at the right answers. And so I do believe that AI is going to help us to, one, own all 24 hours, but then we have to have responsible stewardship of how are we harmonizing the data collected over 24 hours, because we see that you have divergent inputs, you see replications of data. How do you control for that? And then in addition to that, who is the responder? What triggers something to happen? Because the lens from the oncologist might be different from the neurologist, which might be different from the cardiologist. And that, I think, is where we still are trying to figure those pieces out. I absolutely love any type of digital technology, AI technology, but I think that it is with a lot of due diligence on what is the problem we're trying to solve. And even before trying to solve it, who are the stakeholders involved, and getting a really good understanding of how it's going to make a difference. Because we've already seen it explode too many times in healthcare of, this is going to solve all of the scheduling problems. This is going to solve all of this problem. All I've seen is it worsen access, worsen communication, worsen interpersonal interaction. And so I do think that it absolutely is going to revolutionize what we're able to do. And I do think it's going to be the clinicians and the C-suite and the industry who are utilizing this that are going to make the most advancements. But it has to be well harmonized. Otherwise, we're going to end up with the same point solutions that we currently have, and it's not going to make the meaningful impact on patient outcomes the way we would hope they would.
One more point on that, and I know, Sanjay, you have a question, but I want to point out for the audience too, this change in wearables and this enormous corpus of data that we're growing, we may not even know how to apply it yet. And Sanjay and I have both talked about, we wear our Oura rings for 15 years from now, so I'll have 15 years of data. 'Cause I think the power in some of these tools is different than what we were trained in medicine. We look for bell curves and what's a normal hemoglobin. This is a new thing. This is anomaly detection against an individual's baseline, not a population norm. So my Oura ring will tell me my heart rate variability versus myself, and I'm the control because you've got now 90 days of my own
Yeah.
HRV.
Yeah.
And so instead of saying, is this outside the normal range for human beings?
Yes.
It's saying, hey, listen, a sustained drift from 58 to 64 for a heart rate for me is a signal.
Yep.
And it may still be within normal ranges.
Absolutely. The predictive analytics component, so basically it's doing the real world evidence N of 1, right? And I think that is very, very meaningful, because we can't, and this is again reinforcing the idea around biomarkers, and why I hate that term is because the N of 1 that doesn't fit the biomarker, you're never going to be able to intervene at the right time for that person. Where when you're able to utilize your own data in combination with a system of evidence, you now are able to better intervene. And again, some of this isn't new. I look look at some of the work that ResMed has done with ventilators for many, many years, and this was well before this huge explosion has occurred, and they were able to predict when someone was going into respiratory failure. What we're seeing is that that's the type of thing that we are going to be able to do, is that we're going to be able to start intervening earlier, because the more points you have across any curve, the better you're going to be able to predict what does that look like. And just like you said, this now becomes highly relevant in terms of every time there's a change, every time there's a new medication introduced, a medication taken away. At this point, what do? We say, we're going to start this medication. We'll see you back in 6 weeks. Let us know if anything happens. This is what you're expecting to see, and this is what the potential side effects are. You want to explain persistence of use of medication? Yeah, you introduce something where you get more data points along the way, and you now change what a person's outcomes are going to look like.
You said too, I mean, everything you said was just so wonderfully salient and important to consider. But two things that literally Doug and I had discussed in the last week or two over at COA. And one was, I love this, that you said I went back to the company and told them, like, this is where they dropped the ball. I was explaining that this morning in a panel I was in locally, and they were like, well, when are we ready for AI? When can we trust AI? I'm like, look, we have to understand that AI is an iterative and reiterative process. It is not a software that comes out of the box. If we have gaps and unfulfilled needs that we don't have a solution for, and we believe AI can solve them, we need to work together to be able to make this possible in a reiterative fashion. So that was huge. I love that. And you said every stakeholder was one of your top reasons, and that's literally the point of conversation that I'm hearing at all the conferences in April and May of this year. Then the second thing that you said was also to know exactly like what it is you're trying to solve. And that way you can really dissect it, because a lot of people say, like, let's just take this technology and see where it directs us. Sure, maybe one day we can start to learn, what the mind doesn't know because eyes haven't seen. But in the meantime, there's a lot of stuff the eyes have seen that could potentially be, very well suited for with these technologies. And I think that's the best and most disciplined way to do it. Have an idea of how you're going to audit, how you're going to evaluate, how you're going to test and retest even before you prop up the solution, and have an idea of what your understanding is in fullness. That way, when you are met with something that is at odds with your list, you have already done the responsible evaluation, and you don't get misdirected, to use your word that you used beautifully. I wish we could talk to you for another hour, honestly. And I mean, we might know, but we'll have to bring you back. Another thing that we said was the confounder principle. When you were talking about bad data in, bad data out, are you aware of what may be right or wrong? I've read about microbiome effects and those effects that occur due to sleep and sleep disturbances. And I've also read on the other side, right, microbiome and its relationship with the immune system and immune cells and ability to fight both infection and cancer. This is one example where I could see how, is it sleep that's impairing the microbiome that's impairing the immune system? Is it the immune system and this microbiome that are separate? These are the kind of things that I would love, to get insights on over time. And I don't know if you could, speak on that.
Yeah, I would say that that again is probably going to be representative individual of what is the triggering factor, what is the perpetuating factor, and what is the thing that actually makes it come to light. So when you're looking at from a sleep perspective, it definitely can influence your microbiome. So we see this vicious cycle occur with obstructive sleep apnea, that when a person has obstructive sleep apnea and are having more desaturations, that is going to change the microbiome speciation as well as kind of what the quantities are. Because of that increases fragmentation. It also increases the depth of these desaturations. So now I'm increasing the fragmentation. It gives me more reasons for me to have obstructive sleep apnea. So it's a feed-forward mechanism. On the inverse, we also see this kind of relationship. So obviously in the cardiovascular world, there's a lot of attention to sodium. And a few years ago, there was a really interesting publication in Translational Nephrology that had looked at high sodium diet versus like a low sodium diet in animal species. And I don't know about you, but the way that I was trained about it is that it's going to impact your renin-angiotensin-aldosterone system. You're going to have a greater degree of fluid retention, and that is what contributes to blood pressure. Well, what this study actually demonstrated was that there's a selective reduction in lactobacillus that then increased T17, and that was what acted on the kidney. And when they did a selective repletion of lactobacillus, it normalized the blood pressure independent of the sodium diet and normalized the T17. And so with that stated, I think the things that many times we dismiss because it's quote unquote naturopathic medicine or there is evidence is lacking in it. There's a need for us to realize it is with a lot of ego that we think we know as much as we do about medicine. And I think even if I were to take the step back and say, where's AI currently serving the biggest role and most impactful role? I every day use AI. I use open evidence every single day just because I'm like, I have thought about this thing. I just wanna see what's out there, right? It's not my end all be all. It is my teaser that I'm utilizing just to be like, "Oh, that's interesting." A perfect example, earlier today, I was doing a webinar, and there was a question, someone had asked, in advance, and they said, "White noise drives me crazy. I can't sleep with white noise, but you give me some music or a TV, and I sleep beautifully." And I said, "You know what? I've heard that before, but I can't give you a good explanation." I went and I did open evidence, but then I looked at some other things and was fascinated to find that there's been multiple studies that have looked at this and have demonstrated that there's audio masking on the white noise side. It just basically is helping to blur out some of the things that if you live in a city otherwise, where when you're thinking about music, TV, there's a couple of different components. One, an emotional component, but two, if you're a person who tends to be a ruminator and can't fall asleep because you're thinking too much, the white noise is going to aggravate you. You're going to just be paying attention to white noise. Where something that is going to have a slight oscillation, it was showing like a 60 to 80 beat per minute was a goal, decreased your sympathetics, increased your parasympathetics, lower heart rate, lower stress hormones, and really helped in facilitating sleep. So again, nowhere in the American Academy of Sleep Medicine is there any type of guidance on this. Everyone will keep saying things like white noise is a part of sleep hygiene, but really it could be detrimental to some people. And so in the same regard, I do think that that's going to be a part of our future directions.
That is so interesting.
Sanjay, I got one more for you. I know we're running out of time. You got to close us and let these people get back to their lives. But, I'm a student of history and I made a pun about your last name earlier, but,
Mhm.
it's not lost on me. So Morse code was the first technology to prove that you could take a human thought, compress it into a stream of signals and reconstruct it on the other side. Whether you know it or not, here you are a century and a half later doing something that sort of rhymes with that. You're taking 24 hours of human biology,
Yeah.
you're turning it into signals that AI can read, and then you're rebuilding meaning on the other side for the clinician, the patient, in this systems approach that you're doing. So if medicine could finally tune in and receive the full transmission, what would you want it most to hear?
I think that it is truly giving a respect to the full 24 hours and making sure that you're treating to the goals that the person in front of you is asking you to achieve, and not starting from the position of what's important to you as the treating clinician. Really making sure that we're looking at the full person in the full day.
That is so beautiful. There is no better way to conclude. Anne-Marie, we would love to have you back. You're amazing.
Thank you.
And I can't wait to see what you're doing.
Thank you.